Welcome to Oncology Morning Commute. How can physicians use best clinical judgment to determine core drivers for cancer screening? Morning Commute is developed by Projects and Knowledge, powered by Kaplan, and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from GRAIL. In this final podcast of our three-part series, Dr. Christopher Mason and Dr. Pashtun Kasi continue their discussion of multi-cancer early detection tests, this time turning to how to incorporate these tests into clinical practice. Information about the faculty and disclosures can be found at morningcommutepodcast.com/Cancer Early Detect 3. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Mason is a professor of genomics, physiology, and biophysics in the Department of Physiology and Biophysics at Weill Cornell Medicine in New York City. Dr. Kasi is Director of Colon Cancer Research at Weill Cornell Medicine and Director of Liquid Biopsy Research at the Englander Institute of Precision Medicine, also at Weill Cornell Medicine in New York City. I am your host, Candace Hoffman. Dr. Mason will begin our discussion.
Well, hello. Welcome to our final podcast on early detection with multi-cancer early detection testing. And I'm here with Dr. Pashtun Kasi. Dr. Kasi, welcome back.
Oh, thank you so much.
So we'll jump right back in. This is the third leg of a three-legged stool of diagnostics. And we gone through some fascinating subjects of the technology and how the tests work and different tests on the market. But I think for clinicians, probably the big key question is, how do we get these tests into clinical practice? What's the best way to deploy them? Who should get into them? You'd be using these tests. Really, what's the best way to deploy them in an efficacious and really judicious and really useful way clinically? So I think actually we probably couldn't have a better person on the show today to talk about it. You're one of the head investigators and coordinators for the Pathfinder study, and I wonder if you could tell us a little bit about what the study's doing and also what it's trying to expand upon that maybe the original studies might have missed.
I think the key aspect to highlight, I guess, for anybody in the field of oncology and also now early detection, which is applicable to everybody in terms of individuals who don't have cancer to consider screening modalities, is the fact that these tests, as well as the questions, it's a continuous learning that's happening, and it's a continuous refinement of not just the science that's going into the testing, but also how in the real world these assays or tests may perform and how to integrate them into clinical practice. I think it's of value to note, at least for the ones in the United States, that this is the initial Pathfinder study that was just reported out. The follow-up to that, the Pathfinder 2, is something that's already enrolling and already open at many sites across the country, where, again, individuals who made the screening age for some of these different cancers would have the opportunity to have the non-invasive blood test done, and then the subsequent process of, if you do find a cancer signal detected, to determine, if we are able to find it through whatever procedures. I think these would be opportunities to not only get screened, but also opportunities to further understand how this test may form in the real world scenario.
Mm-hmm. Yeah, and I think we're seeing, this is one of the big questions is when you get into the real world, people are complicated. People can be messy. They don't always take their medication. They say they don't smoke, but you can see cigarettes in their pocket. So of all the covariates and what's out there for what we see for patients, how have you been ranking, I guess, some of the modeling for who gets the highest recommendation? So are you looking at smokers, people with that are maybe had cancer recently and looking at minimum residual disease? Are you thinking about alcohol, obesity? If someone's like a New York Giants fan versus a Packers fan, what are the factors that go into your decision making?
I think that's a great question. At one end, you could argue this is a screening, one test for all, something that you might, in a perfect world, consider as part of your annual physical with your primary care doctor by a certain age. Is that the best way forward for some of these tests? But then there are, from a society and cost perspective, the downstream impact or even the sustaining the cost of such an intervention, no matter what the cost is. I think there are these are huge, discussions that are ongoing, and nobody knows the right answer here. At the other end, like you mentioned, is the best use focusing on populations that may be high risk. So, for the ones who are getting the low dose CT scan of the lung for lung cancer, patients who have individuals who have a certain pack years history of smoking, could the blood tests be implemented in those scenarios? And there are some additional liquid biopsies that are pairing that as a composite strategy in some of those screening interventions. And some of the discussions we're having with our colleagues is this something that would be of value in a high-risk clinic, like people who may have a germline mutation that predisposes them to develop certain cancers, like people who have the breast cancer gene or the BRCA gene that can develop, for example, breast cancer, ovarian cancer, prostate cancer, pancreas cancer, amongst many other cancers during their lifetime, or folks who have the so-called Lynch syndrome who can develop colon cancer, uterine cancer, a bunch of different cancers. There are high-risk clinics that are monitoring these patients and also populations. I think there is a big question regarding the variability between the same cancers having different rates. Some cancers are very high in African Americans, in certain people of certain descent. So, do we focus on certain populations more than others? I think those are all questions that everybody's trying to answer, including NCI.
Yeah, and the big ethical questions too. How do you make sure you have some degree of parity and uniformity in the medical system to make sure that, say, African American patients aren't getting underdiagnosed, or that another group of patients is getting overdiagnosed? And as you well noted, of course, things like Tay-Sachs disease and Ashkenazi Jewish populations are very enriched, and so there are already a number of genetic tests there, even just for who people should marry to try and avoid the disease. But I think what's interesting is the other kind of technical component of this, of course, is the human genome is built off of the reference of it is a collection of mostly Caucasian males, and there are pieces of the genome that are distinct between different ancestries around the world, and so some of them we may, just by the nature of how we built our reference genome, be missing some of them for now. And it probably doesn't make too big of a difference, but there will, to some degree, be a need as we can sequence longer and complete references to have an ancestry matched a reference that you use for doing some of your variant calling and to improve what you can basically see. So currently the tests just avoid these areas that are repetitive or complicated. But I think what's interesting is long term there may be other signal in all parts of the genome that you could try and pick up in these repetitive structures or other areas of the genome.
Something that I did want to mention, at least from an implementation standpoint, like you brought up, one model may not necessarily suit all healthcare systems. In some instances, like Canada and other places, there are more so broader screening efforts that may be implemented at a regional or population level, whereas that may be a different strategy for a different place in terms of adoption and how the uptake is. But I do think it would help reduce the disparity given lower cost and ease of administration, including, like as we were discussing earlier, in terms of mobile phlebotomy or even, getting the blood drawn wherever you can or at different clinics. Obviously from a clinical standpoint, this is not necessarily something that has to be at a cancer center. In fact, these are obviously normal individuals. So this is something that would be at the primary care level or the family medicine clinic, or for that matter, any clinic, or even mobile labs. I think that's where you would see that as we see mobile mammogram units and, those kind of interventions ongoing for CT scans. Obviously that's requires a larger resource as opposed to getting a simple blood drawn. I think that there's definitely a lot of potential, but at the same time, there are a lot of questions that we need to ascertain regarding how to implement this in a cost-effective fashion.
Mm-hmm. Yeah, it's going to be payers. It'll be the infrastructure, some of the logistics in hospitals. It's all going to be. It does have a cost, of course, and so I think the stratifying who's high or low risk does help reduce the cost and increase some efficiency, which is great. Which actually gets me to what's the best time or age do you think for testing? I think it's usually we think of older, but there are younger patient populations that have inherited disease or risk of disease. And time of day, there was a paper, actually it was about 4 months ago, that said that cancer cells grow the most when you're sleeping. I don't know if you saw that paper, that based on circadian rhythm. And I posted online in the lab. I said, well, if you're having any trouble sleeping, don't read this, because basically saying, they can listen to the cacophony of cancer cells dividing while you sleep. But it does raise the question of course, circadian rhythm drives much of our biology, including cancer biology. And so, should we get the blood draw first thing in the morning? What do you think about the best time and age for the patients of testing?
I think the age part brings up a big question, because obviously, in general, obviously, the younger you are, I think the biggest risk factor for any cancer is age, outside of other environmental triggers. And that's why you see screening, individuals are not often born with cancers, or often don't develop necessarily cancers earlier in their lifetime, especially with ones that have concomitant environmental exposures and risk factors. But you see the screening of a lot of these modalities at age 40, 50. And I guess the current discussion is integrating it with current screening platforms. And for the ones there is screening, kind of building upon that and seeing if that adds further value or further increasing uptake for there is for cancer where there is screening. For the cancer where there's no screening, again, at least till we get more data, I would say the value may be less in the younger patient population, unless there are patient populations that might further be enriched for certain risk factors that might predispose them for certain cancers. I think it's still an important area to study. But as you noted, even in the initial studies, the actual percentage who may be positive is going to be in the ballpark of 1 to 2%. So it might be lower if you went down on the age. So I think there would be questions regarding the cost and how to sustain that at a population-based level. But at least as of right now, the current studies that are ongoing or prospectively enrolling are taking people who are meeting the current screening guidelines for age-appropriate cancer screening.
Yep. And I think some of these big studies you're mentioning will really tease that out. So, for example, the National Health Service in England is doing a large study now for multi-cancer early detection testing, and the age is there between 50 and 77 throughout England, and they're getting 140,000 people that have signed up. So, there I think we'll know very soon. It's possible maybe you have to go to 45 instead of 50 as the lower bound, or maybe 50 catches almost everything, and that just gives people peace of mind. But then they also are looking at other risk factors. So I think it's very fascinating to see the field develop. So I think some of the other questions that come up in terms of implementation. So okay, we've got this great test; it's relatively easy to deploy. Uptick is really abound, and people are excited. But when you think about in the clinic and you have practice, there's questions of staffing. How do you report the results back? When you have mutations that are very clear, also ones you've been looking for, because you have an indication it might be related to a tumor type or a cancer that you already had a hunch about. What do you do though when you have more unclear results or results that are variants of unknown significance? Do you at all work with genetic counselors or do deployment? What are some of the on the ground complications you've seen with in your clinic? I've definitely seen in my own hands tubes being mislabeled. I've seen people shipping them to the wrong address. I've even seen some of the companies will get the box and still sits for 2 days. So there's all sorts of things that can happen when you're shipping tubes around. But what have you seen in your practice?
I think some of the challenges and questions, as you brought up, are similar questions when genetic testing for hereditary cancers or determining if something is running in the family were being done, and how that impacted, coverage and even life insurance and disparity there, and then disclosure of results. Even to this date, like you mentioned, if you had a variant of unknown significance, what does that mean? What do I need to do differently? In oncology, at least with scans, there is that term called scanxiety, where patients who are getting scans, they have this anxiety of this test. What if it shows something? Who are in the survivorship looking for whatever cancer. I think with blood testing too, they in the study as well, they described And there are obviously stories out there as well about individuals who had the test and the test is saying it's positive, but they never found any cancer. Obviously downstream you're doing, let's say, a PET CT scan or whatever imaging modality. None of these tests are perfect. So what if you have a situation where the signal is, you have a person who knows that maybe they have cancer, but you don't find cancer? Is it just the fact that you've caught it so early that nothing is detectable, or there is that continuous learning and refinement that's happening? Is it picking up a signal that, what if it's truly false positive? I think those are obviously ethical considerations, and those are informed discussions that probably need to happen before the testing is done in the clinic. This is something that you would want to have a frank discussion with the individual as to what are we going to do with the results of the testing before the results come back. You need to have that discussion and plan. If it's a negative, what's the cadence and what am I going to do with the result? And if it's a positive, what's the downstream steps that are going to be done based on what the results can be seen. So again, those are informed discussions, and maybe for some individuals, maybe this is not a consideration. Again, that would be an informed discussion and a shared decision between the patient's care provider and the patient and the caregiver. But in some instances, it would make sense that it would have universal adoption. But we've been, as oncologists and clinicians, we respect the decision and the fact that there might be some individuals who might say maybe that's not something that they want to know, and that's fine. But I think that conversation has to happen before the testing is done.
Yep, absolutely. I mean, I think there's and also you think about just impact on the family. Right? So if you've got you're suddenly find out you're a high risk or you even have early stage cancer, if you have a sibling who's also 50 or 53, should they go get tested? You guys sort of look at hereditary cancer risk. Most of the panels today do not do that, but as we do sequencing and more of the genome, we look at other areas, we'll start to pick up people with, risk of very clear hereditary cancer, other just diseases that they could be at a higher risk factor for. So the science is new, but we'll start to see it.
And I would say, I don't think anything is 100%. I think we have to realize that fact. I don't think it's anything against one assay or one technology. I think nothing in science and nothing about humans is 100%. There's going to be variations. There will be new data. There will be learning that will continuously happen. So I think the key is to learn from the ongoing studies and the pros and cons that might come about and the challenges that might come out in certain situations. In the previous podcast, we talked about how in some of the studies they were having cancer site origin detection overlap between cancers that had similar biology, like the HPV virus causing head and neck cancer, causing cervical cancer, causing anal cancer. There was, from what I saw in the paper, there was overlap of some of the matrix. So they did detect a signal of the cancer. And if you look at the methodology that has gone through iterations and stuff, at some point in time, they have to fix the number of panel and what you're going to study. There's going to be some compromise between how the assay and test may perform for a certain tumor type, and that's fine. I think that nothing is perfect, but I think that it's important to realize the limitations as one implements this assay, or even if you're not somebody who is ordering it. I think the technology is already there. You might be the person where somebody may be bringing in a report for you to interpret. So I think we can't get away from this. I think it's here to stay, liquid biopsies and also for detection. So even if you're not the person who's ordering the assay, you need to understand what would be the downstream consequences and how to interpret the results of these assays and the nuances between the strengths and challenges of any of these assays.
Yeah, and one of the things that's actually come up has also been a surprise is when you sequence the samples. If you do panels or you do capture, you'll be have these bespoke targets. But in other cases, in studies we've done and others, if you sequence everything there, you can pick up mutations, but you also sometimes pick up latent infections or viral reactivation. You can start to even pick up other things you weren't planning to look for. Or this also was called occult tumors in patients for non-invasive prenatal testing, where mothers who are pregnant or soon to be mothers are pregnant, just getting tested, and you can pick up also rare cancers that way. So there's often surprises when you go looking and sequence deep, you'll find things for sure. So we'll close with one thought just on patients who are coming in, say with already that have mutations, say germline mutations. And we have seen patients together who come into the clinic with already carrying, say, BRCA mutations or other existing germline risks. And have you seen a lot of that? Do you feel like that? In some sense, it gives you a positive control in the data. You know, one of the mutations to look for. But how has that affected some of your care? Any sort of tips for other clinicians out there when they start to see some of these more complex patients?
I would say with the cost of some of these testing becoming cheaper, the adoption has been for more panel-based approaches, and we are picking up more patients with these aberrations or individuals with these aberrations who otherwise traditionally would not have met guidelines. There are numerous works recently published this year where it has increased the number of people by 10-20% who otherwise, if you just had followed the guidelines and family history or the age, you might have missed these instances. So, you know, in those high-risk individuals, would something like an early cancer detection assay help?
Yeah.
In addition to the ongoing screening programs? I think that's a great research question, because I can tell you there are very varied practices. For example, what to do with a patient who has BRCA who might be at risk for pancreas cancer, in terms of how frequently do I do an MRI, or do I do an EUS, or do I do yearly blood draws, or things that are not as specific. So, you know, at a broad level, obviously integrating it at every primary care level is one question, but then at a more sophisticated, enriched level, are these individuals who are high risk for other cancers, where they may have a non-invasive blood tool added to their current screening paradigm?
Yep, I think it's there's a beautiful note on that the complementarity and getting as much data from every test, but also putting in the context of everything else we know about the patient is, of course, the best way to find disease and hopefully prevent it, or at least if it's there, then to treat it. So, well, that is the final podcast on early detection multi-cancer testing that we're doing. And Dr. Pashtoon Kashi, thank you very much for joining us. I'll see you in the hallways of the hospital or the Greenberg building, and look forward to seeing you on campus again soon. And thank you so much for joining. And thanks to everyone who joined us on your commute. And hopefully you are not picking up any exceptionally large numbers of mutations. Have a great day.
Remember to receive your credit and evaluate this program. Please visit morningcommutepodcast.com/Cancer Early Detect 3. You can find all of the episodes in this series and all of our other podcasts on your favorite podcast streaming services, or download our Morning Commute app. Thank you for joining us today.